All right, so I'm giving actually the first lecture about changing paradigms in the inflatable penile prosthesis reservoir placement. And these are my disclosures. And why I'm so happy to give this talk is because the penile prosthesis, many of you may not know this, was invented in 1973, the inflatable, by Brantley Scott, Baylor College of Medicine. Baylor College of Medicine is the home of the inflatable penile prosthesis. Many of you may not know this, but in 1972, a year before, he invented actually the artificial urinary sphincter. So he was a visionary, had a lot to offer, and unfortunately, he died in a plane crash. A true story. He used to build his own planes. He built them. He'd fly. The first one, it crashed, but he survived. He built another plane, flew it again, it crashed, and he died. But again, a lot of what we know about the penile prosthesis was due to Brantley Scott. Well, when Brantley Scott first invented the inflatable penile prosthesis, he actually placed the reservoir in the space of Retzius. He found that was the easiest place to place the reservoir. But there have been numerous places to place the reservoir. In Germany in the 1990s, they actually used to place the reservoir in the peritoneal cavity. There was no lockout valves at the time. It was very difficult to prevent autoinflation. But this quest to find the perfect location to place the reservoir has been going on for many years. And if you ask many of the residents, if you think about the part of the procedure that caused the most anxiety for residents and people learning this procedure, it's really placing the reservoir, right? That's the part that you really want to think about. So think about some anatomic considerations. When I'm doing the surgery with the residents, I say, you have to drain the bladder. And I make us drain the bladder twice. Why do I make it twice? Because if you don't drain the bladder and you only have 200 cc's in the bladder, you're 2.6 centimeters away from perforation. 2.6 centimeters from perforation at only 200 cc's. If I drain the bladder, it'll keep me almost 7 centimeters away from perforation. The other important thing you have to remember is 40 degrees lateral, 3 centimeters is the external iliac vein. So the residents know when you're operating with me, I keep shouting, medial, go medial, nothing lateral, 3 centimeters lateral, you're in the external iliac vein. So there have been a lot of complications with placing the reservoir orthotopically. And orthotopically, I'm going to use interchangeably within the space of Retzius or the retropubic space. Some of them have been bladder perforation, which I've mentioned, lacerations to the iliac vein, small bowel erosion, herniation, intracutaneous fistulas. And you have to be very careful in the patients who've been radiated. You have to be very careful in the patients who have a pelvic surgery, and particularly patients who are going to have renal transplant. Because if they're going to have a transplant surgery, you're worried about that reservoir and someone going and cut your reservoir or infect your reservoir, so it could be an issue. So here's some pictures, and you can see on the upper left, and upper right, you can see that there is an erosion into the bladder with the reservoir. You can see on the bottom left is where you can see it intraperitoneally. In the upper and bottom right, you can see that the reservoir actually migrated right below the liver. It's all migrated all the way right below the liver. So again, we worry about migration and herniation. Well, in 2002, Steve Wilson said, I got a better idea. What I'm going to do is I'm going to place these reservoirs and I'm going to place them submuscularly and ectopically. Ectopically meaning that I'm not going to go through the inguinal ring. I'm actually going to place it below the rectus muscle above the transversalis fascia. So here's a picture, and you can see what he did with he started doing it with the AUSs. He basically placed it below the rectus muscle above the transversalis fascia. The problem is it's very visible because these are not flat, they're round. Right, so it could be a little bit of an issue. And the other problem is that's going to herniate, right? It's going to easily come out through the inguinal ring. So in 2010, we started coming out with the flat reservoirs. And what's really nice about the flat reservoirs is that the profile is only 2.5 centimeters. So you can conceal a flat reservoir much better than you could conceal those round reservoirs. So now placing it ectopically makes more sense. So here's a depiction as well of placing that a reservoir, and it's again below the rectus muscle, above the transversalis fascia. Now it's flat, and this is what we define as an ectopic reservoir placement. So there were some studies looking at the difference between ectopic reservoir placement and placing it in the space of Retzius. And some of the things you'll find is that when you place it ectopically, there's more chance for revision because patients can feel it and see it. Autoinflation tends to be more common when it's placed ectopically, but the part that really gets a lot of attention is the herniation part. So it's really a tenfold increase in terms of herniation because it just comes right back out through the inguinal canal. It's not fixated. So Al Morey that year said, look, I got a better idea. I'm going to use a forced clamp, and I'm going to take that reservoir and I'm going to place it up as high as I can. I'm going to place it up as high as I can so that I can mitigate that risk for herniation. And this is placing up the reservoir as high as you can, again, below the rectus muscle. The problem is that you still can get intraperitoneal placement because the higher you go, the more risk you can get into the peritoneum, higher chance for visibility. And I always remind the residents, remember the rectus muscle is the thickest in the middle, and as you go lateral, it gets very thin. Well, when Al Morey described this, he talked about going towards the ipsilateral nipple. The more lateral you go, the more visible it is. So I don't like going lateral. I like staying medial, and I like staying low. There were colonic injuries, reservoir migration, and there was also herniation. So there have been two techniques that have been described to prevent the herniation. One is called the THALIA Stitch by Toby Kohler out of the Mayo Clinic, and the other one was the transfascial fixation, which we described here at Baylor. The THALIA Stitch essentially is taking the crowns from the tubing, the quick connects, and putting the suture through it, and actually suturing that suture to the pubic bone so that that tubing cannot migrate. So it's basically fixating the tubing of the reservoir and suturing it to the back of the pubic bone so it will not migrate. And he called it the THALIA Stitch. We later described what we call TFF at Baylor, the transfascial fixation, and we came with the idea because I started putting in the artificial urinary sphincter through the inguinal canal, but it did herniate. So what we started doing was we started fixating the tubing. And the way you fixate the tubing is essentially you take the right angle, and I'll show you a video, out to in through the inguinal canal, grab the tubing, and bring it out and fixate it through the fascia. We published a small series of AUSs where these patients were getting the transfascial fixation. Only one patient could feel the pressure regulating balloon, but there were no complications, no herniations, no revision. So essentially this is what it is. You take a right angle, you put it through the inguinal canal, you go out to in, and you grab the tubing and pull it through. We did some cadaver work as well. If you can start from the upper left, you can see that you basically will take the right angle, put it through the inguinal canal, and then you can work your way down. You can see we grab the tubing and pull it through. I have a video to show you as well. So here's the video, and this is just a brief video. Again, we always drain the bladder. We drain it twice. In our operating room, we always wear 2 gloves. We tape the bottom glove because bacteria can always be at the base of that second glove. So we double glove. We change our gloves probably 6 or 7 times throughout the case. And here's the S retractor. So basically, so it's very important. If you want to be in the right place, you don't just stick your finger in the inguinal canal and put the S retractor in. 9 out of 10, you'll be in the wrong place. You have to take the muscle off the pubic tubercle and come below the muscle. If you come below the muscle and flip your finger, you got to be able to feel the back end of the muscle when you feel it. As David Hinojosa describes it, he says you got to feel the meat. You got to feel the meat. And so that's exactly right. So here you'll see in just a second, the S retractor is there. You're going to see this side of this is the inguinal canal, and you're going to basically see a right angle, going to have a Babcock on it, and I'm going to basically take my finger in it, and I place a right angle, and I will pop through the fascia, so it's out to in. You'll see it there. Then we'll take the tubing, and I'll grab the tubing, and I'll pull it through. Once we pull it through, you have locked the tubing into the fascia. It is physically impossible to herniate. There's a 0% chance this will herniate. Because what you're going to do then is you'll take that reservoir and then we'll place it again below the muscle because I've already torn the muscle off the tubercle. I'm going below the muscle and I'm going towards the umbilicus. I don't go towards the ipsilateral nipple. I go towards the umbilicus. So our technique is low submuscular with transfascial fixation. That's what we call it. Low submuscular with transfascial fixation. So we presented this, we published this in JSM. It's 31 cases with the low submuscular transfascial fixation. It's about 30%, 1% of patients say they can feel it. I mean, if you do ectopic, you're going to be able to feel it, but none of the patients were bothered by it, which is very important. The overall satisfaction was 4.5 out of 5 on a Likert scale, no revisions and no complications. So this is pretty much our go-to, particularly if patients have had a radical prostatectomy. We want to stay out of the abdomen. Okay, so you have a lot of options when you place a reservoir, and we have moved most of our work towards the low submuscular with TFF. I will tell you that probably the best incision you can make, or the best reservoir placement you can make, is the counter incision. Because I tell the residents, if you're not sure, if you're in trouble, always make the counter, right? There's no shame It doesn't mean that lack of confidence. The counter will always be perfectly fine. So this is, we do the low submuscular, but again, if there's any questions, you make the counter, you'll never get in trouble. So again, in summary, orthotopic reservoir placement can be associated with an increased complication rate, but over the past 10 years, there's been evolution towards ectopic reservoir placement. High submuscular reservoir placement can be associated with increased visibility, bowel injury, inferior epigastric injury, and reservoir migration and herniation. But the low submuscular placement with TFF seems to have a low complication rate with increased patient satisfaction. Thank you for your attention. Before we move on to our lunchtime symposium with Dr. Miner, do we have any questions or comments about reservoir placement? Everyone feels pretty comfortable. Yes, Mike.
Couple things. If the patient has had previous groin surgery, previous inguinal hernia with mesh, you just go to the other side. What if it's bilateral? How does that affect your placement approach?
A counter.
Counter.
Just make a counter, because I can never go wrong with the counter.
And when you do the counter, you're doing a muscle splitting incision, getting just extraperitoneal.
It's exactly right.
Is that right?
I'm putting it in the exact same location I would have put it if I went through the ring. So essentially, we're making a very tiny incision into the fascia. We put stay sutures in, take our finger, and we actually muscle split wherever we are, because I go lateral, put it right under the muscle, and put it above the transversalis fascia.
Above the transversalis. So you shouldn't be right on the peritoneal surface. You should have one little layer between
That's right.
your placement. Yeah, because I've seen people try to do that and sweep the peritoneum off and tear the peritoneum, and now you can see the intestines.
Yeah.
What do you do then?
You close it and you
close
put it on the other
go
side.
elsewhere.
Yeah, right.
Okay.
But it's very important, as you mentioned, do not go below the transversalis fascia. Keep that. And so I tell if you keep your finger like a C, as soon as you break through it, you can feel the belly of the muscle, right? All you're trying to do is feel on the top of the belly. Don't poke through. Keep it like a C, and you'll be right in the right place.
Great.
Yeah.
Thank
you. Any other questions or comments? Dr. McDonald.
I just had one question. Presuming this is relatively recent, you haven't had to take any of these out, but I'm thinking about the person who comes after and has to revise these. Do you think there's going to be any issues with, like, you're going to have to divide that bridge of fascia, correct? And the tubing will likely sit right on the spermatic cord.
Yeah. The best part about this procedure is that the revisions are so much easier.
Oh.
Because I don't have to look for the reservoir. I literally go to the ring, I grab the tubing because it's sitting through the fascia, I cut it and pull it right out. Otherwise, I'm fishing and I'm digging, right? And this way I know exactly, because it's not high, it's low, it's right behind the pubic bone. And that little trick where it's sitting through the fascia is my go-to. And I got it. So it's much easier, and I'm not fishing.
Great presentation. Let me just say I was very fortunate chance to work with Brantley Scott back in the late 70s, early 80s. And one thing about Brantley, he was always questioning in the operating room, what can we do to make this better? What's the anatomy? How can we make this better and simpler and safer and everything easier for the patient? I just want to take my hat off to you, because he would love this presentation. He would salute you for what a great job. Time will tell if this is going to be better than what we've been doing. I personally still like to put the reservoir where I've always placed it. I still use the inguinal inserter. I still go open incision, taking out the old reservoirs frequently. Yeah. But this is fantastic.
Yeah.
Congratulations.
And I want to say thank you for coming. He trained with Brantley Scott. He was Dr. Coburn's chief resident when he was a medical student, and we're very happy to have you.
Thank you very much. Yeah.
Any other questions? Please.
Hi, Dr. Khera. Drew Zalavi, former UNM resident. I know a lot of folks just do the simple thing, default to the counter incision. So for someone who says, I'm just going to do the counter incision all the time to make it simple, what's the sort of the best case against that, to say, well, here's the sort of the argument of why you maybe should try not to do a counter incision every time, the theoretical downsides or proven downsides of it?
Yeah. I can't think of a lot of reasons why not to make a counter, except there's another incision, more pain, right? Another incision. But I look at people that are kind of like my mentors. So one of my mentors is Al Morey. Al Morey, I think no one does it better than him when it comes to like the way he thinks. And Al Morey was the one who came up with the ectopic idea. He's the one who came up with the high ectopic, all these ideas. If you ask Al Morey today, what does he do? Counter every time. Every time. I said, you invented this. He said, nope, counter every time. He said, I don't want a single phone call at night. That's what he told me. And I said, okay, right. And then so I think the argument is, yes, you're making another incision. It's the visibility, more pain theoretically, but that's about it.
Okay.
Yeah.
Thank you.
Well, great. Thank you very much. Really appreciate it.